I'm Dr. Nigel Carter, Chief Executive of the Oral Health Foundation, and I'm delighted to introduce you to this webinar. We've recently been working on a project in association with GSK to produce a white paper on the recommendations and usage of denture adhesives. Funding for the production of the white paper on denture adhesives was provided by GlaxoSmithKline to the Oral Health Foundation, but they had no editorial input or control on what we've produced. As a student, I was taught very clearly that if a patient had to use a denture adhesive, then we had failed in our production of the dentures. So what we're going to consider today with our expert panel is whether denture fixatives are in fact related to the oral health quality of life, or whether they are still an admission of failure. The project that we've been involved in has involved an international global expert panel with experts ranging from Japan through to America and a number of experts in Europe. I'm joined today by three of those experts: Professor David Felton from the University of Missouri, Professor Angus Walls from the Edinburgh Dental Institute, and Dr. Guy Gothan from King's College London Dental Institute, who are each going to deal with an aspect of the subject. Our expert panel consisted, as I said, of experts from across the globe and who are really renowned in their field and met several times to produce the guidelines which are being launched today. The white paper that we've produced is science-based and comes up with the best available knowledge that we have on the use of denture adhesives and their benefits for oral and general health. So I now hand over for our first presentation to Professor David Felton, who's joining us from the University of Missouri.
Hello, I'm David Felton. I'm the Dean of the University of Mississippi Medical Center School of Dentistry, and I'm a prosthodontist. And my topic is Complete Dentures, a Thing of the Past. This is a highlight of the overview of my presentation. We'll talk about what is edentulosum. We'll talk about the daily and long-term impact on patients who have no teeth. We'll talk about the global burden of having no teeth. And we'll talk about some treatment options, and then we'll talk a little bit about dental adhesives. Edentulosum, according to the Glossary of Prosthodontic Terminology, is the state of being without natural teeth. So that's where a patient has no natural teeth, either primary teeth or permanent teeth. The impact is pretty dramatic. If you think about a patient that looks like the slide on the right side of the screen here, a patient who has no teeth or no replacement teeth is going to have a great deal of difficulty in chewing many types of foods. So their diet typically becomes very soft and very carbohydrate rich, which leads in many instances to obesity and diabetes and other health considerations. Also, without teeth, and because the tissues, both hard and soft tissues, tend to resorb over time, you have a dramatic impact on the patient's aesthetics, which has an impact on their self-esteem, their quality of life. And because you have no teeth in the back part of the mouth here for a patient to chew on, you have an issue with support of the joints. And there's an example of that. The long-term impact really is for the potential for chronic denture-related irritations. We know that over time the bone and soft tissues remodel and resorb, but the dentures don't. This is due to continual bone loss, especially in the lower arch where it's accentuated, and this can have a dramatic impact on the general systemic health. Here's an issue where patients have sores in the mouth that are caused by ill-fitting dentures. And there's some good evidence to suggest that these chronic irritated areas can actually turn into oral cancer. We know that bone loss is continual from the time the teeth are removed, and it's chronic. So a patient starts out at a bone level that you see here in this particular panoramic image, and over 15 or 20 years, or 30 years, it may end up looking like this. Typically, the maxilla resorbs at one rate and the mandible resorbs at a greater and more rapid rate. And this was actually categorized many years ago by both Atwood, as you see here, and by studies by Tallgren out of Scandinavia. And the white lines here indicate where the bone originally started on this particular patient, and you can see where the bone has resorbed to. And again, it's accentuated in the mandibular arch. We had a patient that presented to our school last year who said, my lower denture no longer fits. And we looked and it didn't, and in fact we took a panoramic image, and she had been headbutted by her grandson, and that actually broke her mandible. So you can see where the arrows show here that her mandible is actually broken on each side. And again, if you have chronic bone loss in the lower arch, you end up having issues that can be related to fracture of the mandible. There's some very good indications out there and very good evidence to support the fact that tooth loss and denture wear can contribute to overall poor systemic health. We know that edentulism is a global problem, and you can see some of the data here from Rafael de Silveira and colleagues, and it can range anywhere from 12% in the United States up to 63% in other countries. There's a good review by Kassenbaum and colleagues that looked at over 285,000 patients that were evaluated over a 20-year period. And while they did find that the rate of edentulism decreased from 4.4 to 4.1% between 1990 and 2010, there's still almost 300 million edentulous patients globally. We know that edentulism rates vary within and between countries, and we know that the primary determinants are age-related issues. We know that education levels have an impact, smoking has an impact, poor oral hygiene has an impact, and it's interesting to note that patient income levels are probably not a determinant of tooth loss. Interestingly, according to the World Health Organization, a patient that has no teeth meets their criteria for being physically impaired, disabled, and handicapped. And when I learned that about my edentulous patients, it really did bring home the fact that I needed to do something really extra special for them. So what are the treatment options for treating the patient that has no teeth? And as you can see here, this patient is devoid of teeth in both arches. We can make dentures, which are a good alternative for these patients. The positive impact of having dentures in a patient that has no teeth is it does improve the ability for them to chew, gives them the opportunity to chew things they couldn't do without teeth. It does improve the aesthetics because it replaces not only the teeth but the soft tissues. It improves their quality of life and self-esteem, and it does support the temporomandibular joints. However, we still know that long-term use of dentures will lead to bone loss. Our goal is to provide our patients with incredibly well-fitting dentures. The positives of that are that we have very good opportunities to have good adaptation or fit of the upper denture. The dentures do replace both hard and soft tissues, the teeth and the gingiva. There's balanced articulation can be provided, which can help stabilize the dentures, and they're relatively low in cost. The downsides are that while the upper denture fits usually very well, the lower dentures are where most patients have problems. There's movement and instability of the lower dentures, and there's continual bone loss beneath both the dentures, which require relines or remakes. And unfortunately, one of the biggest problems we face is that very few people have a very adequate denture recall program in their practices. So these patients aren't seen except when they break something or when something hurts. How do we improve the fit of dentures? Well, denture fit is really related to the polymerization shrinkage of the acrylic resins as the dentures are fabricated. And we can overcome those by improving our impression techniques, by injecting molded dentures, which helps minimize the polymerization shrinkage, by milling the dentures with CAD/CAM technology, or by the use of dental adhesives. So here's a lower custom tray specific for a patient that's been border molded properly, and you can see we have an optimum complete denture impression. On the lower left part of the screen, we have an injection molded denture that's being fabricated, and on the right side is a CAD/CAM denture, both of which will help minimize the lack of fit of the denture base. And our goal is to provide the patient with not only an aesthetic but an incredibly well-fitting denture that's in proper occlusion. What we don't want to see is patients that show up in our practices like this, where the teeth are worn, the dentures don't fit, the patients have done home relines to try to facilitate an improvement in fit, or where they're using excessive denture adhesives to help retain or stabilize these dentures. We have alternatives. They include dental implants. Here's a single implant in the lower midline. That's the intaglio surface of the denture showing the retentive element. This happens to be a press-eclix attachment. And we can put 1, we can put 2, we can put 3, or we can even put 4 or more. And particularly for that patient that has the incredibly abraded and eroded lower arch, these can be very successful. And there's 4 in this particular patient. If we have enough bone in the posterior aspects, we can put implants in those regions and give great stability and retention to the denture. And that's this particular patient. We can also put multiple implants in the lower arch and put a screw retained prosthesis that doesn't come out of the mouth. The problem with that long term for these patients is that as they age or become more arthritic, how do they clean this prosthesis? Because if they can't clean it properly, regardless of whether it comes in or out of the mouth, there's an increased risk of aspiration pneumonia for these patients. And we need to keep in mind the fact that not all edentulous patients want dentures, not all of them can afford dentures, and not all of them need dentures if they have a decent amount of remaining bone and soft tissues. For these patients, optimal complete dentures are very acceptable. The question is, how do we minimize the bone loss? And this is a patient that I've treated recently that has worn dentures for 20 years. And if you look at the red circles here, it shows the mental foramina. So even after 20 years of wear, this patient still has quite a bit of bone in the lower jaw. The next patient has been wearing dentures for 45 years, has a little more bone loss, but not excessive compared to some of the patients I've shown earlier. And this last patient has been wearing dentures for over 50 years and still has a very good amount of bone remaining. This patient doesn't necessarily need implants. They can function very well with complete dentures. So how do these patients maintain bone over this 20 to 50 year period of using dentures? I think we really need to revisit the information from Togren and Atwood, because I don't think they told the whole story here. Is it that the patients have good genetics? Is their home care very good? Is it a lack of inflammation? Is the occlusion correct on the dentures that they've worn? Or can dental adhesives help in these conditions? You have to start the process with properly border molded and custom trays and impeccable final impressions, as I discussed earlier. And if you notice the sets of dentures here, this is the tissue contacting surface on the upper and the cameo surface on the lower. This is on the same patient, and you can see there's a dramatic difference between a properly border molded and extended denture and one that's not. The properly border molded one gives good support and stability, the other one does not. So can dental adhesives help, or does that necessarily imply future or failure of the dentures? And the answer is absolutely not. There's great information out there that looks at the fact that dental adhesives can improve the retention of dentures, the stability of dentures, and the masticatory chewing efficiency, especially in well-fitting dentures. And there's the references shown there. So in summary, edentulosum continues to be an enormous global health concern burden in both developed and developing countries. It does not appear that the need for complete dentures will disappear in the future, so dentures are not a thing of the past. We're going to have them around for a long time. The criteria for predicting the long-term effects of edentulosum on any individual patient are really lacking. Properly constructed and well-fitting dentures are an acceptable treatment for our edentulous patients. but adhesives can help these patients. Thank you very much.
Thank you, David, for that excellent presentation. I'd now like to hand over to Professor Agnes Walls from the Edinburgh Dental Institute, who's going to talk to us about the denture experience, the complete denture experience for the patient, and what impact that has on the oral health related quality of life. Angus.
Nigel, thank you for those kind words of introduction, and also the opportunity to take part in this webinar for the Oral Health Foundation. It's a real pleasure to have been part of the working group and to produce this white paper, which I hope will help the profession move forward in terms of its understanding of the values of denture adhesives. David has told us quite clearly about changes in edentulous around the world, and I thought I would put this initially in the context of England. And you see here data from 2009 from the most recent Adult Mental Health Survey and population projections spread out to 2029. So the population of England in 2009 was 50.65 million, and by 2029 that will have grown to 60.26 million. But the proportion of those who are edentulous is falling quite rapidly, as is seen by the red elements on these columns. And so in 2009 there were about 2.8 million people who had no natural teeth, and that will have fallen in 2029 to 0.52 million, a really huge change in oral health status, and one that we need to think about in terms of delivery of care to this part of the population. Edentulism is something which has been falling dramatically in the UK, as can be seen by these data from the National Studies of Adult Mental Health over the last 40 years. And perhaps the most interesting thing on this particular illustration is the trend line. And this is the trend line for people who were 35 in 1968, 45 in 1978, and so on. And you can see that initially the rates of edentulism within this age cohort rose, and then it fell from 1988 down to 2009. And I would pose the question, how does edentulism fall? And the only explanation for a fall in the rate of edentulism is selective mortality. People who wear complete dentures die younger than those who do not. Now that doesn't mean that wearing dentures causes you to die. There's an awful lot of social confounding in here, because edentulism very much is part of the life experience of the poor and the inaccessible in this country, as opposed to the wealthy and the affluent. So what about complete dentures? What do we think that they are? From my perspective, complete dentures are a very poor prosthetic replacement for a natural dentition. They're two lumps of pink plastic that float around inside the mouth, and our patients, our clients, have to juggle them with their lips and their tongue to allow any form of sensible function. And put in that context, they are a very, very poor prosthesis. In terms of aesthetics, they can be quite good, but in terms of function, they pose very significant challenges for our clients, for our patients. So what factors do patients value in terms of dentures, complete dentures, and denture function? They value most the ability to chew, and then the ability to speak, followed by comfort, stability, and appearance. And you might think that that's odd, but fundamentally teeth are about chewing food and enjoying food, and are about communication. And we need to think about that in terms of the context that we're talking about here and the stability of complete dentures. So if we look at dentures and quality of life, and these data are from Mark Thomason and his colleagues from the University of Newcastle, looking at quality of life in the edentulous patient, and you'll see there's a huge range from people who are very comfortable with their quality of life and dentures at one end to people who have very significant barriers and inhibitions at the other. And I'd just like to share with you some quotes from this study telling us about the quality of life and individuals' experience. And we'll start off at the good end. So at the good end, the most comfortable dentures I've ever had. They're fantastic, they're brilliant. And as for eating, I eat anything. And it doesn't affect us. It doesn't affect me, us as the Geordie vernacular. I can manage it, no problem at all with these dentures. Mark assures me that they were made by one of his dental students in the dental hospital. But at the other end, of course, you have things to do with public constraint, such as carrots and greens and all. You're supposed to eat plenty of them being a diabetic, but I can't bite them unless I mash them. There again, if you go out to a meal, you can't sit mashing them. It doesn't look good, but at home, it doesn't matter. Sometimes in my own house, I would sit and peel an apple into slices and, eat it like that. I like apples, but I wouldn't sit in front of you now and eat that apple because I feel conscious. When I go out for a meal, I would never dream of ordering a steak. I would have something softer, fish or chicken or a stew of some sort, casserole. I love steak and I have it at home, but I would never order it in public. That would be the least bit difficult. Other than that, I don't say I have any difficulties with his dentures, yet he can't eat. And of course, there are also social constraints. Avoiding kissing my partner or laughing hysterically because they, her dentures, flew across the kitchen floor one day, and that was horrendous because I hadn't known him very long. Can you imagine the embarrassment? But he's still with me though. Not altogether bad news, but still a real handicap as far as that individual is concerned. And so quality of life is really important, as is chewing efficiency. And you see here images of people with a limited number of natural teeth and an individual with complete dentures and no natural teeth. And we see differences in chewing efficiency between those individuals. And those differences in chewing efficiency drive a change in food's choice, in the foods that people choose to eat. And that change in food's choice, in turn, results in alterations in diet and dietary intake. And so if we look at diet and dietary intake in this population, initially from the standpoint of digestion, there's been remarkably little work done. The only published data go back to those of John Farrell in 1956, some 60-odd years ago now. And what John did was to get people to take bags of food, muslin bags of food, and chew them for a different number of chewing strokes and with different force. And after that, they would be swallowed and then retrieved about 2 days later. And on retrieval, he analysed the content of the bags in terms of digestion of the food. And what he showed was that digestion was dependent on the food type and independent of the extent of chewing. So arguably, we don't need to chew food with modern foods preparation. But if we change the foods that we eat because of food's choice and limitations associated with complete dentures, then we change our dietary pattern. And that change in dietary pattern has been demonstrated both in the UK and the US and many other countries. And so if you look at this table, it shows you foods intake or food group intake for people with an intact dentition, defined here as having 20 or more natural teeth, a compromised dentition having fewer than 20 natural teeth, and those who are edentulous. And if you'll see, if you scan across this table from left to right, that people with an intact natural dentition eat more and consume more than those who are edentulous, whether it's protein, NSP, which is fibre, calcium, niacin, vitamin C. Vitamin C perhaps is the one exception here, largely because of fortification of fruit juice, particularly in the US. And we also see the figures in red, which are the figures which are below the nationally recommended intake, and nobody appears to achieve the right amount of fibre in their diet, but those who have no natural teeth consume less than 50% of the daily recommendation in terms of fibre intake in the UK and in the US. And so do these apparent variations in intake of foods influence nutrient status? And the answer is that they do. If we look at blood biochemistry, we see reductions in plasma vitamin C, plasma retinol and plasma alpha-tocopherol, all key micronutrients in the body's defense mechanisms. And so what do we know about denture adhesives and how they might influence the changes I've just described? And there are a limited number of studies in this domain that I'm going to share with you. The first here from David Bartlett and his group, a very small study, but did show increase in fruits and vegetables intake over a 30-day period and did show improvements in oral health-related quality of life associated with adhesive use. Nicholas and colleagues, an improvement in oral health-related quality of life, and they showed quite clearly here that in group 2, which was a group who used an adhesive for one time period and then stopped, that improvement in quality of life decreased when adhesive use was stopped. Colleagues this time from Buffalo in New York State, and these were studies that were undertaken by using dentures or denture-wearing individuals who had been part of the prosthodontics master's program to the State University of New York. So these were very well-made, well-fitting dentures. And yet, within that cohort, the use of a denture adhesive was associated with improved retention and stability of the well-fitting dentures, fewer dislodgements were reported when eating crisp foods, and greater confidence. So we see higher levels of bite force, we see higher levels of denture wobble in those not using a denture adhesive, and we see improvements in confidence, in comfort, and in satisfaction in those who were using a denture adhesive. And finally, a more recent study from Brazil looking at denture stability and mandibular movement. And again, we see improvement in the patient satisfaction with denture use in those who are using an adhesive, and altered mandibular movements with increases in vertical movements during chewing and less lateral movement during chewing on the right-hand side of these two sets of kinesiographs where the individual was using an adhesive compared with those on the left where they were not. And so in summary, complete dentures are a poor substitute for natural teeth. The use of complete dentures affects oral health-related quality of life and both food's choice and nutritional intake. And finally, the use of a denture adhesive improves patient confidence, oral health-related quality of life, and chewing function, and may result in improved dietary choice when associated with correct dietary advice. Nigel, I hope that's helped to put into context some of the recommendations in our white paper, and I turn the table back to you.
Thanks, Angus, for that excellent presentation, which I think really does start to put some context to the role that denture adhesives might play. I'd now like to hand over to Dr. Guy Goffin, who's responsible for a lot of the research of various evidence and recommendations around the world, which we looked at when putting the white paper together. Guy, over to you.
Thank you, Nigel. Hi there. Unfortunately, I have to apologize first for my English. I'm not a native English speaking. I'm coming from Belgium and my mother tongue is Flemish. But I will speak slowly, so I'm sure you will understand what I want to tell you about. And in fact, I would like to present to you a global report on evidence-based guidelines for the use of denture adhesives and their benefits for oral health and general health. And I'm very pleased and very happy to do that. Mainly, first of all, because it's the first time that we have looked at all the guidelines who are available in the literature, and we have tried to synthesize it to one set of guidelines for denture-wearing patients so that they know how to use a denture adhesive, when to apply it, and how to apply it. Secondly, I think it's an important report because it also I think refer to what is available in the science and evidence on why dental professionals should recommend more often and more consistently denture adhesives to their denture-wearing patients. Therefore, I think improving the health of their denture-wearing patients and so that they can live their life at the fullest. My presentation, I have some agenda I would like to introduce a little bit, and that's probably some repeat from what Angus just told us. And then I would like to go with you through the challenges and opportunities that are associated with the use of denture adhesives. And then we come to the science-based guidelines on the optimal use of denture adhesive creams and the evidence that exists for consistent professional recommendations for denture adhesives. This report at the end, we ended up with a call for action on the professional side, but also on the research side to do something more to really improve further what we have developed now. As Nigel said before, we had a very, very relevant global task force brought together by the Oral Health Foundation. We had Professor David Bartlett from King's College in the UK. We had Nigel Carter from the Oral Health Foundation, Professor David Felton from Mississippi in the US, Professor Kawai from Japan, who was very helpful, Professor Frauke Müller from the University of Geneva in Switzerland, Professor Gregory Polizois from the University of Athens in Greece, and Professor Angus Walls from Edinburgh, UK. And I think we had a group of people who were really known as experts and key opinion leaders in terms of the gerodontology and of prosthodontics. And bringing these people together helped us to develop this global report. As an introduction, as we heard from Angus already, dentures are made for people who have lost some of or all of their teeth. Usually as a dentist we think very much mechanically on how we can replace teeth by our natural teeth by artificial teeth, let's call it. But I think dentures do more. Dentures help patients to improve their appearance, support their lips and cheeks, improve their self-esteem and confidence, improve their chewing ability, and so help maintain healthy nutrition, as we just learned from Angus as well. So I think as a dental professional we have to start thinking a little bit beyond only the mechanical and think about what we can do for our patients to make their lives much more comfortable, much more enjoyable, even at a later age. Edentalism, as we just learned as well, if we look at it globally, there is a decline in edentalism around the world, but it's still highly prevalent. If we know that on a global basis, about 33% of the 65-year of people of more than 65 years old are edentulous. That's a huge number. We see that there is a difference between developed countries versus developing countries. And it has a lot to do with socio-demographic factors, for instance, the education, lifestyle habits, smoking, or health conditions like arthritis, asthma, diabetes, and others. We have seen that as I said, in the majority of developed countries we see a decline. But for instance, in the US, we see that the rate of edentulism is quite stable. Has to do definitely with socio-demographic factors, because we see in certain areas of poverty in the US where there is still an increase in edentulism, where in other areas there is a decline. At the end, we ended up with a stable level of edentulism in the US. But overall we can say that in developing countries there is still a highly increase coming up, because people are not educated, they don't have the same opportunities like the developed countries for taking care of oral hygiene and taking care of their teeth before they have to be extracted. So coming to denture adhesives. I'm not going into the details about the composition of the denture adhesives, because that will take us too far away. But three major components are part of the modern denture adhesives on the market. First of all, they have the adhesive agents who are delivering the adhesion between the denture and the mucosa. There is antimicrobial agents reducing the microbial growth in the adhesive, and then other agents to help with application, storage, freshness, and so on. On the market there are different forms. Creams, powder, and strips are the most known. When we looked at the literature with the team, we found out that on powder and strips there are very, very limited scientific reports on the efficacy of these particular forms. And that's why we have focused on where the most of the science is, and that's on the creams. So whenever we talk in the future now on these guidelines, think about denture adhesive creams. The working mechanism is quite straightforward. It's a combination of physical and chemical properties. And the physical properties really come from a combination of cohesive and adhesive forces. I don't know if you still remember from your students' time what cohesion and adhesion means, but the cohesion is the one that keeps the things together in the adhesive layer, and they are related to the level of hydration coming from the saliva mainly in the mouth, and then the formation of fibrillar structures in this physical adhesive layer. The adhesion properties coming between the adhesive layer and the mucosa on one side and the denture on the other side. And it is the combination of these two different adhesive and cohesive forces that makes the adhesive really work in the mouth. Okay, we learned already about the good things about denture adhesives in terms of diet and so on from Angus. I will at least touch briefly on the health challenges that also exist with the use or maybe misuse of denture adhesives. You are probably all of you are aware of this toxicity of zinc-containing denture adhesives. It was a couple of years ago that there was a lot of media coverage of denture adhesives containing zinc, and people who had some neurological problems, probably related to the high level of zinc in their bloodstream. Now, if we look back at what started this whole discussion a couple of years ago, it was really 2 case studies in the US. And when we looked into more details of these case studies, then we found out that the 2 people were really people that had very bad fitting dentures. They had old dentures who didn't fit very well anymore, and they were using massive amounts of denture adhesives. Then it's not surprising that these people were taking in a lot of zinc, leading to a really hyperzincemia in the bloodstream, and higher levels of zinc automatically reduces the level of copper. And copper seems to be the most important reason for neurological problems that can arise from this type of ingestion. So that's why the FDA, also the Food and Drug Administration in the US, never made any official statement to say that zinc-containing denture adhesives were not allowed anymore. A lot of manufacturers, and most of the important manufacturers at least, then came up with a zinc-free form of the adhesive, or with a lower level of zinc in the denture adhesives. But I think the most important reply we have to this one is really try to get people only using well-fitting dentures and not overusing the denture adhesives. A second health challenge possibly that people can come up with is the microbial growth. Because of the antimicrobial properties of the adhesive, we could create a kind of disbalance in the microbiota in the adhesive. And that could lead to some negative problems, I would say, and also the increase of, for instance, overgrowth of certain bacteria could be compromise the level of health in the patient's mouth. If we looked at the literature and the team that I just talked to you about, they looked into the literature and we couldn't find any reference to any study that was showing that there was really a change in microbiota in the denture adhesives that could lead to a disbalance or any negative effects on the oral health of the patients. So again, this is probably a little bit overstated, and it's not really a big issue because there is no whatsoever evidence for that one. Another problem, and that's probably much more relevant, is the application and removal of denture adhesive. At this moment, and we looked at the literature and we looked at on the internet on different sites and everything to find out what is the optimal way of applying denture adhesive. And there is very few guidelines available at the moment. And that's one of the main reasons that this global task force found it really relevant to develop these guidelines now for optimal use of denture adhesives. So that's one thing. The other one is the removal of denture adhesives. And there is still some research to be done. Honestly, we didn't find any of the particular guidelines or guidance that existed on the removal of denture adhesives being sufficiently scientifically supported to really help or give us any guidance on how to remove denture adhesives. However, the removal is important, and we come back to that in a second. The last point is oral cancer. Still, people think about oral cancer and relate it to denture adhesives. What is also, again, following the literature search we did, not really existing. The oral cancer is related to probably ill-fitting dentures. And it could happen that people who are not have well-fitting dentures are using more denture adhesive and to overcome that problem of the ill-fitting dentures. What could then at least could create a kind of barrier for dental professionals to see the oral cancer early enough to get it treated. So there is a risk for oral cancer related to ill-fitting dentures, not to the use of denture adhesives, but there could be a relationship because of the masking of the oral cancer by the denture adhesive. But there is a lot of opportunities, and already we had some, you got already some information from Angus about it. Denture performance comes through technical excellence during the manufacture of the prosthesis, and coming from you, dental professional, but also from the dental lab, of course. And then there is this improved perceived comfort while using the denture by effective management of the patient. And I think there as well is there kind of, I think we have to highlight that probably the effective management of the patient is not always done properly as it should be by dental professionals because of the focus that we have on the technical excellence. There is definitely an increasing a possibility to increase the patient's sense of security and satisfaction through improved retention and stability, chewing ability, increased chewing performance, like we just learned from Angus, and the reduction or elimination of buildup of food debris beneath the denture. We'll come back to that in a second as well, but it seems to be a very important one. And recent research showed that about 86% of denture wearers are complaining about the food debris staying underneath their denture and making them feeling uncomfortable. So the comfort and the improved comfort while using a denture is an important topic, as an important reason for using denture adhesives. Today, oral health and general health cannot be looked into in isolation anymore. There is too much. If you look at the recent FDI, World Dental Federation, let's say definition of oral health, it includes all the well-being, social well-being, and all the other areas of feeling well and health status related to general health and to oral health, and that's also relevant for general health. We know that chewing difficulties in older patients are associated with the activities of daily living, cognitive status, and even depression. Other studies have shown that there is the poor oral health status was predictive of a poor general health status. And there is even, and Angus referred to that one already, the study from David Bartlett, there is some limited evidence that exists that people with complete dentures or use dental adhesives will eat a healthier diet. But there are challenges associated with the use of denture adhesives. As we already said, there is a lack of existing guidelines on the optimal use of denture adhesives. We looked at the internet, we did a search everywhere, and we couldn't find a very, let's say, consistent guidance in any direction on any of the existing websites from dental associations, but also from manufacturers. So, and the second point is that dental professionals have not been recommending their use consistently because they do see prescribing denture adhesives as a way of compensating for poor quality of prosthodontic care, a poor reflection on their clinical skills and prosthetic expertise, as Nigel already said before. So these were the big challenges that we as a global task force looked upon and tried to answer to a certain degree. And so we developed these science-based guidelines on the optimal use of denture adhesives. Number one, apply a small amount of denture adhesive cream to a clean and dry denture 1 application a day should be sufficient. This is important to communicate that to your patients because easily they overuse it and they apply more than once a day, and it's not needed if the denture is well fitting. After application, we place the denture in the mouth and firmly close the mouth for a couple of seconds. If the adhesive cream overflows, too much has been applied and the adhesive should be removed. It's important because it should not be swallowed. And patients should not consume food or drink within the first 5 minutes of application. Third guideline was before sleep, the denture should be removed. The denture and the oral cavity should be thoroughly cleaned and to remove any of the remaining adhesive. In another white paper that we developed about a year ago, we also talked about denture care, and I refer to that white paper to see how you can really clean the best your dentures, even after the use of denture adhesive creams. And then all patients who wear removable dentures should be enrolled into a regular recall and maintenance program with their dental professional. So it's not because they once have their denture that you should not see your patients back. You have to make sure that they are enrolled in this recall program so that you can really control and the fit of the denture, and also if you have to adjust your recommendations for the use of denture adhesive. So these were the guidelines that I think are important that there is now a consensus of this global task force. These are really experts. So I think these guidelines should now be, and that's one of the things that your Oral Health Foundation will take on board, is trying to get these guidelines out to everybody, and especially to the dental wearing population, but also to caregivers and dental professionals around the world. The other challenge was the evidence for consistent professional recommendations for denture adhesives. And I don't want to come back to all the reasons that dentists are not recommending it, but there is enough evidence at this moment. If you look at the literature, if you look at all the benefits that are scientifically proven of the use of denture adhesives, there is enough evidence to make a consistent professional recommendation for denture adhesives towards patients. Here the guidelines that, or the guidance that the team wanted to give is that, first of all, patient satisfaction has become a decisive factor for the overall success of prosthodontic treatment in full denture wearers. It's not the fit or the mechanical fit that is the only thing. It's the patient satisfaction who is really important at the end. Secondly, denture adhesives can enhance the retention and reduce foot accumulation beneath well-fitting, and it's underlined, complete dentures. It's really important that these people can eat again some like peanuts or raspberries or grapes or whatever, so that they don't have to think about the issue of accumulation of these little seeds underneath their dentures, and also because they can really open their mouth well and have a normal chewing cycle. Denture adhesives can be beneficial to the patient because they may enhance comfort, as we said, provide psychological satisfaction, and that's especially true in the social interactions that these people have, increase confidence and thus well-being, increase retention and stability, and improve the function. And we have to think about these are not older people who are sitting there and not doing. They live their life much longer now and are living their life and want to live it at the fullest. And that's why we need to really think about how can we improve their comfort. The effectiveness of denture adhesives cannot compensate for significant denture deficiencies. It was something that the team was very strict on, that this should be set and clearly spelled out, because it's the dentist's responsibility to deliver a denture that has a fit based onto the anatomy and the functional structure of the patient. It should have a perfect intervalvular space. There should be a very good centric relation. There should be a balanced occlusion. Also, the peripheral and posterior seals should be provided, and there should be a balance of muscle activity around the oral cavity. This is the dentist's responsibility, and these are important to have these well-fitting dentures made, and this is the basis for any of the other guidance that we just gave. Dental professionals should provide guidance and instructions to the patient on the current application and use of the adhesive and on removing it and cleaning the dentures, as I just referred to before. And finally, the optimum time to advise on the use of an adhesive varies between patients. There is no evidence for one or another, but for well-fitting dentures, the team thought it might occur at a review appointment, and for patients finding problems with compliance, it could even happen at the time of the fitting or soon after. Therefore, the recommendation of the team to the Oral Health Foundation was, please provide independent and impartial advice on the optimal use of denture adhesives to dental professionals, because they are the first line for recommendations to patients, to caregivers for elderly people. More and more people end up in homes where some caregivers have to take care of the health of these people, and directly to denture wearers. And the call for action, as I said before, there is still some open questions. We need to disseminate more widely the benefits of and the scientific evidence supporting the value of using and recommending denture adhesives towards the dental professional world, because this is essential to helping complete denture wearers recognize the improved satisfaction they can get from the use of a denture adhesive and improving the service that a professional can provide by recommending a denture adhesive more often. These were the two action steps that this team came up with, and I really hope that the Oral Health Foundation can help us to bring that message out towards the world and improve the life of all the denture wearers. Up to Nigel again.
Thank you, Guy, for that excellent presentation. As Guy's referred to, we've produced the white paper with the recommendations that you've just seen, and that can be downloaded from the link that you now see on the screen. So I think we've conclusively shown there that there is a role in today's world of dentures for use of a denture adhesive. And perhaps Guy's referred to eating fruits, getting things stuck under the denture, nuts, seeds from fruit. Perhaps one thing to think about is what it's like when we have a stone in our shoe. It's very similar for the denture wearing patient when they get a pip under their denture. So what obligation do we as professionals have to those patients? And I think that is to recommend, where appropriate, in addition to providing them with excellent fitting dentures, the use of a denture adhesive. I recommend the white paper to you. Thank you for listening to this webinar, and a huge thanks once again to our three contributors, David in the US and Angus and Guy here with me.